Welcome to all the dignitaries present here. I'm Rimpa from ClearNet, serving as an allocated session assistant to ensure a seamless experience. ClearNet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet served as a digital partner for this event. So the focus of today's session is neurosurgery, posterior fossa tumors. For this, I would like to invite Dr. A.L.Meenakshi Sundaram sir. MBBS DA MD is a distinguished professor of anesthesiology and former dean and DME at several government medical colleges, including Theni, Stanley, Chennai. A respected leader in his field, he has served as National Vice President and Governing Council member of Indian Society of Anesthesiologists and has held key roles in ISA Tamil Nadu state branch, including president and state secretary. So now, without much delay, I would like to hand over the session to you, sir. Please proceed with your talk.
Thank you, Oda Clearnet. Now I request our President, Dr. Munian, to offer the presidential address.
Good evening to all. I am Dr. K. Munian, President of ISSCT branch. On behalf of ISSCT branch, Puthukkottai, we are conducting online webinar every week. I welcome all the delegates. I welcome moderator, speakers, and our academic chairman and the delegates for the online webinar conducted by Puthukkottai ISA in the name of Puthukkottai Bhudhan. Today we are conducting 13th episode of second edition. Today we are going to discuss about the cerebral pathway and the posterior anesthesia for neuro anesthesia for posterior fossa tumor surgery. I am honored to address the critical role of anesthesia, specifically posterior fossa tumors. Posterior fossa contains many vital parts like brainstem, cerebellum, and cranial nuclei 3rd to 12th. Lesion in this area will provide various symptoms and signs like mass effect and the increased intracranial pressure, which is a vital, which is a life-threatening complications of the posterior fossa tumors. Key considerations for anesthesia in posterior fossa tumor surgeries: maintaining stable intracranial pressures and hemodynamics. It is a crucial for preventing complications, ensuring successful surgical outcomes. Even a small space occupied lesions can result in increased intracranial pressures, which is a life-threatening complications during surgery. Second one is cerebral blood flow and oxygenations. Factors which are influencing the cerebral blood flow like carbon dioxide levels, oxygen tension, hematocrit, and increased temperatures which are vital for the optimal anesthesia management. Patient positioning and physiological effect. Our useful positioning is important because to increase the surgical access and the physiological stability and prevent the neuronal injuries. Anesthesia techniques and monitorings. Routine perioperative investigations are needed. Our primary goal is maintaining hemodynamic stability, cerebral perfusions, and closely monitoring for the potential complications. Then intraoperative monitoring like routine invasive monitors, routine non-invasive monitors, and invasive monitors, placement of CVP catheters are essential to detect early complications. Neurological monitoring, somatosensory evocative potentials, and motor evocative potentials, and brain auditory evocative potentials are useful to early identification of the neuronal injuries. Challenges and complications. Venous air embolism, which is a life-threatening complication of the posterior fossa tumors surgery in the setting positions. And brainstem cardiac reflex are essential for the early identification of the hemodynamic instability. Postoperative complications like pain, nausea, vomiting, and pneumocephalus and hydrocephalus and increased intracranial pressures are the life-threatening complications. Conclusion: anesthesia for posterior fossa tumor surgery requires careful planning and precise technique and close monitoring. By understanding the unique challenges, consideration of these procedures, we can provide optimal care for our patients and successful outcomes during surgery. Thank you all. Thank you, Master.
Thank you, Mr. President. Now I request Dr. Kannan, our secretary, to offer the secretary's address.
Good evening all. I am Dr. Kannan, Secretary ISA Puthukkottai branch. Successfully, we are conducting 13th webinar of second edition of Puthukkottai Bhudhan today. Today our topic is neurosurgery, posterior fossa tumors, and I welcome all our eminent speakers to the webinar. I welcome all delegates to the webinar. Last week, 9th April, we have conducted 12th webinar smoothly. Last webinar topic was anesthesia machine. We have divided the topic into 3 subtopics. First one is laryngoscope, including video laryngoscope. Second one is low flow anesthesia. And third one is safety features in an anesthesia machine. Our moderator was Dr. Madhusudan Upayada, Professor, Kasturba Medical College, Mangalore, Karnataka. First subtopic, laryngoscope, including video laryngoscope, done by Dr. C.V. Shetty. She is postgraduate, Kasturba Medical College. She has explained laryngoscope with the introduction, history, uses, types of laryngoscopes, and parts of laryngoscopes with pictures, different types and their advantages, disadvantages. She has explained technique of laryngoscopy with axis, maneuvers to improve laryngoscopic view, and complete view of laryngoscope blades and its types, and also McCoy flexible tip blades. She has explained video laryngoscopes with steps of video with the flow charts. And second subtopic is low flow anesthesia. This topic was done by Dr. Megha. He is associate professor, Kasturba Medical College. She has explained low flow anesthesia with the introduction, need for low flow anesthesia, and from theory to practice, history. She has explained Baker's classification with the gas flow, metabolic flow, minimal flow, low flow, medium flow with graphs. And she has also explained the requirements for low flow anesthesia, methods to achieve desired gas and agent concentration. And third subtopic is safety features in anesthesia machine. This topic is done by Dr. Julie Miskut. She is associate professor in Kasturba Medical College. Ma'am have explained the safety features with the high pressure system, cylinder safety considerations, pressure regulators, and oxygen failure protection devices, oxygen plus, traditional flow meters, mechanical linkage, high pressure alarm system with the APL valve, pressure valve of. She has explained all with specific diagrams clearly. And last webinar was attended by 1006 delegates. We are very happy to inform you we have reached our aim, and we are expecting more delegates to attend the webinar successfully. We need your continued support to continue this academic program. We thank our academic chairman, Dr. Meenakshi Sundaram sir, and all delegates, our ISA Puthukkottai members. Thank you all.
Thank you, Secretary. Now it is my turn as a thematic address. I have to introduce the faculty to you. At the outset, we are very happy, as our Secretary pointed out, we have reached our target of 1,000 audience in the 12th episode itself. So consistently, we were 933, then we extended so much of a pressure, then 946 we reached, then even in Solapur, when I visited, I appealed. Everywhere we wanted to spread the message, and we have crossed 1,000. Now we are not stopping with that. Now we have revised our target as 1,500. So we want to reach 1,500 members. And this neuro anesthesia will try to improve the attendance, as it is a very vital topic. And this time, the youngest person, the postgraduate, Murari Bharadwaj, is from Begusarai, Bihar. He is a Dipindi resident in Tata main hospital, where these two consultants are working, Seelora Sahu and Amlan Swain. So he is interested in running race and ball badminton. The same way, I think Dr. Amlan Swain is also interested in ball badminton and running. So both of them are doing the same thing, whether they learn anesthesia or not. He is running with his consultant day in and out. So we welcome him for the symposium, and it will be followed by Dr. Seelora Sahu, a polite lady She is qualified in neuroanesthesia, DM neuroanesthesia, and she is a senior consultant in Tata Main Hospital, Jamshedpur. In addition, he is assistant professor, Manipal Tata Main Medical College. So it is the biggest medical college in Jamshedpur, and Madam is an academic coordinator for DIP&B program. And she is interested not only in neuroanesthesia, but she is interested in art, hiking, trekking. I don't know how she will go trekking, avoiding neuro injuries. So Madam is a neuroanesthetist, so she is very careful about that trekking, and she is interested in travel also. Travel means whether he will be traveling with Amlan Swain or leaving him and travel, I don't know. But Madam is interested in traveling. And Dr. Amlan Swain is also a DM neuroanesthesia graduate. Now, you should know these people again mutually anesthetized. Neurologically, it worked out well. So, both are DM neuroanesthesia and both are spouse. So, that is a good thing to see. And he's also a senior consultant in Tata Main Hospital, and she's an assistant professor in Manipal Tata Medical College. See, this Manipal Tata Medical College and the hospital is a 983 bedded hospital. And this is our 13th episode. We have to remember the Tata Main Hospital caters 13 specialties with the DIP&B post-graduation. So again, he is also a DIP&B graduate, Murari Bharadwaj. So these people dedicate their life for neuroanesthesia. So when they participate as a unit, it is quite nice to see Puthukkottai Bhudhan is achieving a target. So these people are very good. And again, to moderate these people, we need a top person by name Dr. Manisha Katikar. Manisha Katikar, madam, I know only for 25 years. Just 25 years I know. So madam is a good human being. She is a consultant anesthetist and intensivist in Balwant Institute of Neurosurgery. See, she is a consultant, but actually the owner is also Dr. Manisha madam only. So she is from Solapur, Maharashtra. So I am seeing him from the step by step. Madam is improving both in anesthesia as well as in family life. Madam is a first rank holder in diploma anesthesia, that we should know, and she is a second rank holder in MD. Madam has delivered all prestigious orations in Maharashtra. So the most popular will be Tambe oration in Nagpur. Even I was also fortunate to deliver that oration. And Madam is a recipient of COLS award by ISA National, and she had 15 publications to her credit, both national and international. And Madam has delivered nearly 200 lectures across the country. And Madam has delivered a lecture in Puthukkottai Bhudhan also in the first episode. And she's a mentor in a mentorship program of World Federation Society of Anesthesiologists. Madam was Secretary Maharashtra State ISA. Madam was President Maharashtra State ISA. And Madam is now a governing council member of National ISA. That means she is slowly improving. By participating in Puthukkottai Bhudhan or not, I don't know. Madam is steadily improving. And Madam is a Dean, College of Indian Society of Anesthesiologists. It is CISA, now it is called as. So Madam is a person, and more than that, she is a good housewife also. In spite of all these things, everyone should know, Madam takes care of, because I know her mother-in-law also, the elderly mother-in-law, Madam used to take care that, so that she proves that she's a good human being. In addition, she is running a powerful WhatsApp group. In the northern segment, we call it as Nari Shakti, that is woman power. So Madam is such a powerful lady, and she is also doing only neuroanesthesia. And we are happy to have her as moderator for this session. And even Amlan Swain, when I said Madam is the moderator, he said, sir, she is our senior, I will talk to her. So that sort of a respect she commands in neuroanesthesia. So I request Madam to continue with the session. Madam, over to you.
Thank you very much, respected Dr. Meenakshi Sundaram sir. It is my great pleasure and in fact honor to join this session and I'm really happy to know that Puthukkottai city branch is doing so well. They have crossed 1,000 number of attendees who are learning and attending these kinds of academic sessions. So heartiest congratulations to you, to Dr. Munian, to Dr. Kannan, to Dr. Hemash Sivakumar for continuously conducting such kind of programs so regularly. We all know that posterior fossa tumor surgeries are very important. Posterior fossa, already Dr. Munian sir has explained that it is one of the vital structures in the brain. And if so many PG students are joining, and it definitely comes as a long question to in the theory, as well as many questions are asked if you get a case of any neurosurgical case as far as the CSF dynamics are concerned. So even if you get a case of hydrocephalus or a meningomyelocele, the question will go on basics of CSF dynamics, and a question will go how the CSF is formed, how it is circulated. So it is very interesting to know, because once you know the physiology of CSF dynamics, then only you will come to know about where will be the obstruction, what will be the effects of those obstruction, which foramina is blocked, and why this patient has developed hydrocephalus, whether it is a congenital hydrocephalus and why, or whether it is acquired hydrocephalus. So we have an eminent PG student, and Dr. Bharadwaj, to speak on CSF dynamics. So let's listen from Dr. Bharadwaj. Dr. Bharadwaj, please.
Good evening, everyone. Today I'll be discussing about the cornerstone of neurocritical care, that is CSF, its pathway, ICP waveforms, and monitoring. Understanding these concepts is critical for managing conditions like traumatic brain injury, hydrocephalus, and stroke. This is the outline of my presentation. I will cover 10 key areas. First is CSF basics, then its production and composition, then CSF pathway, ICP fundamentals, ICP waveform components, Lundberg waves, monitoring techniques, clinical indications, interpretations and clinical implications, and summary. So now let's start with the CSF itself. CSF is a clear colorless fluid, which is an ultrafiltrate of plasma contained within the ventricles of the brain and subarachnoid spaces of the cranium and spine. Adult CSF volume is estimated to be around 150 ml with a distribution of 125 ml within the subarachnoid space and 25 ml within the ventricles. It is produced at the rate of 500 ml per day, and the turnover time for total CSF volume is around 5 to 7 hours, giving a turnover rate of about 4 times per day. What is the role of the CSF? It gives mechanical protection. It acts like a water bed for the brain. It maintains homeostasis, that is delivering nutrients and removing waste products. It provides buoyancy, reducing the brain's effective weight from 1500 grams to just 50 grams. And in composition, it is low in protein and sugar, and it mirrors plasma electrolytes. This is a table showing the CSF volume and pressure in children and adults. In this, we can see the CSF volume gradually increasing. From in infants, it is 40 to 60 ml, whereas in adults, it increases to 100 to 160 ml. And the CSF pressure in children is around 3 to 7.5 millimeters of mercury, and in adults, it is 4.5 to 13.5 millimeters of mercury. So now let's look at the CSF journey. 70 to 80% of the CSF production is done via a network of modified ependymal cells, also known as choroid plexus, in the lateral third and fourth ventricle. The remaining 20 to 30% of the CSF formation results from the oxidation of glucose into water and carbon dioxide by the brain tissue and ultrafiltration from the cerebral capillaries. CSF flows from lateral ventricle to third ventricle via foramen of Monro, and then to fourth ventricle via aqueduct of Sylvius. And finally, through the foramen of Luschka and Magendie, it enters subarachnoid space around the brain and spinal cord. Absorption is done via arachnoid granulations, which acts as drain, emptying into dural venous sinuses. Blockages in the pathway causes hydrocephalus, which can be obstructive due to clogged aqueduct or can be communicating due to failed absorption of the CSF. So now coming to the intracranial pressure basics. ICP is the pressure inside our rigid skull. Normal ICP is around 4.5 to 13.5 millimeters of mercury. But what happens when the volume increases? The Monro-Kelly doctrine says that the skull is a closed box, and if one component expands, such as brain, blood, or CSF, the other must shrink. For example, when blood volume increases, the CSF and venous blood are displaced. And when compensation fails, ICP spikes to more than 20 millimeters of mercury, risking herniation of the brain contents. So we have to remember that brain tissue is incompressible. Even a small amount of volume change can be catastrophic. Now let's discuss the ICP waveforms, a vital sign for the brain. In this picture, we can see on the left side, there is a normal ICP waveform. Here P1 is percussion wave, which is sharp peak from the arterial pulsation. P2 is tidal wave, which reflects brain compliance, and normally it is smaller than P1. And if P2 is greater than P1, then compliance is failing, and we have to act fast. P3 is dicrotic wave, which is due to venous rebound after the aortic valve closure. So pathological patterns increase in P2 and P3, which indicates reduced compliance. Plateau waves, which is due to sustained rise of ICP. It's a red flag for the herniation of brain contents. And loss of P2, P3 distribution suggests severe edema, and this waveform is our real time guide for the brain's space status. Now coming to the Lundberg waves. Lundberg waves are like EEG tracing of ICP. A waves are plateau waves, which occurs due to sustained rise of ICP in the range of 50 to 100 millimeters of mercury for 5 to 20 minutes. It is indicative of severely reduced intracranial compliance and imminent herniation. B waves, second picture, is rhythmic small spikes. In this, ICP is in the range of 20 to 50 millimeters of mercury, and every 30 seconds to 2 minutes. It is linked to respiratory cycle, and it often seen in early compliance loss. C waves are tiny frequent oscillations tied to systemic BP changes. It is also known as Straub-Herring-Mayer oscillations, and these waves are crucial for monitoring ICP trends, diagnosing intracranial hypertension, and giving interventions. Now coming to ICP monitoring techniques, it can be invasive or non-invasive. Invasive methods include intraventricular catheter, which is a gold standard. It is placed in the lateral ventricle. It measures ICP and can also drain CSF. The disadvantages are risk of infection and hemorrhage. Second is parenchymal monitor. In this, a fiber optic probe is placed in the brain tissue in white matter. It also gives accurate measurement of ICP, but there is no therapeutic option, or there is chances of drifting away over time. Third is subdural or epidural bolts. It is less accurate and used only if ventricles are collapsed. There are some non-invasive methods also, which includes optic nerve sheath diameter by ocular ultrasound, transcranial Doppler. These are emerging, but they lack precision. Now coming to clinical indications of the ICP monitoring, which are severe traumatic brain injury with GCS of 8 or less. Guideline mandates it to prevent the secondary injury. Second is hydrocephalus. EVDs can be used to diagnose and treat the hydrocephalus. In stroke, in hemorrhagic or large ischemic stroke with edema, it is used. In CNS infection, meningitis or encephalitis with increased ICP, and in post-surgical cases such as of tumor resection and shunt revision surgery. Now, interpretation and the clinical implications. When ICP rises more than 20 to 22 millimeters of mercury, we have to intervene in a stepwise manner. First, we have to elevate the head end of the patient to 30 degrees and improve the venous drainage. Second is osmotherapy. In this, we can use mannitol or 3% saline, which draws fluid from the brain. Third is hyperventilation. It is a temporary measure. When we decrease the CO2, it causes vasoconstriction and decreases the blood volume, and there is a risk of ischemia if it is used for the prolonged period. Fourth is CSF drainage. EVD can be used to remove the fluids. And last is surgery. Decompressive craniotomy, it is the last resort. And regarding prognosis, if there is sustained rise of ICP over 25 millimeters of mercury, it is shown that more than 80% mortality is seen. Now, summarizing, this CSF is a dynamic fluid. Its flow and absorption are key to hydrocephalus. ICP waveforms are clinical gold, especially the P2 elevation and A wave signals disaster. And monitoring ICP in traumatic brain injury, stroke, and hydrocephalus, we have to act aggressively when threshold is breached. Thank you. Now I'm handing over my presentation to Dr. Amlan, sir.
It was really an excellent presentation, Dr. Bharadwaj. Very to the point. All important aspects have been covered. All important points have been covered. It is a very vast topic. The ICP monitoring itself and the ICP waves and description of it. But I think you have presented the presentation is so good that whatever is required for the practical knowledge of managing a posterior fossa case, that has been already explained by you in a very nice way. So congratulations for this nice presentation. And Meenakshi Sundaram sir, can we go on to the second presentation now?
Yes, madam.
Yeah. So I invite Dr. Sahu, Dr.Seelora Sahu, who will be speaking on pathophysiology as well as presentation of posterior fossa tumors. The posterior fossa tumors are the commonest pathology that we encounter, and Dr. Bharadwaj has already explained about Mandro-Kelly doctrine. So brain is a compact rigid structure, and anything anywhere in the brain is going to cause, either it is a blood or a clot or a tumor, anything is going to cause rise in ICP. Posterior fossa structure, posterior fossa is very vital, and Madam will now explain us about the presentation of various symptoms as well as pathophysiology related to posterior fossa tumors. So it is very common. The PG students must know that posterior fossa tumors are the commonest pathologies that are seen, and also pediatric patients are the most commonest age group that comes with posterior fossa tumors. So, Madam, please.
Thank you, ma'am. Thank you to Dr. Murari for summing up the importance of the cerebrospinal fluid and the intracranial pressure. Now, as Madam already told, posterior fossa lesions are one of the most common lesions which lead to an increase in intracranial pressure and the complications associated with. Before moving on to the pathophysiology of posterior fossa lesions, first I'll go through what are the presentations or how the patients usually present when they have a posterior fossa lesion. So this is just a scenario which will give us a better idea of the clinical presentation of these kind of cases. So the patient will usually present with chief complaints of on and off headaches since, for example, on and off headaches since the last 1.5 years, frequent blurring of vision since last 6 months, difficulty in walking since 6 months, and frequent vomiting. Now the headache is of 1.5 years duration, bilateral, episodic, throbbing in type, and lasts for a few hours. It is usually associated with nausea, and there are no preceding aura or positional variation. No history of any change in sensorium, no aggravating factors, and it is relieved after taking rest. The visual disturbances are gradual in onset, spanning over a duration of 6 months, lasting for 5 to 10 seconds at a time, and then it recovers by itself. At least 5 to 10 episodes every day. No aggravating or relieving factors associated. Patient presented also with difficulty in walking, which was gradual in onset, progressively increasing over the period of last 6 months. And there is history of falling onto the left side, very commonly in the recent past. The patient is unable to walk and incoordination of movements is observed. And he has been or she has been observing inability to climb stairs as of now. There is also associated vomiting, which is sudden in onset since the last 15 days, progressively increasing, sometimes up to 2 to 3 episodes per day. The vomiting is projectile in nature, preceded by severe headache, and usually the amount is a cupful of recent ingested food material, foul-smelling, bilious, and non-blood stained. The patient also gives a positive history of loss of appetites in the last 2 to 3 months, associated with generalized weakness, difficulty in holding objects, and difficulty in combing hair and wearing slippers. There is no history of trauma, fever, syncope, or seizures, sensory loss, tingling, altered sensation or numbness, radicular pain, altered sense of smell, or double vision or defect in color vision. There is also no history of difficulty in chewing, numbness present over face, deviation of mouth or drooling of saliva, tinnitus, deafness, difficulty in swallowing of food, or regurgitation. There is no change in voice, slurring of speech, altered taste sensation, involuntary movements, restlessness, forgetfulness, dysarthria, dysphagia, or altered sensorium, and the bowel and bladder disturbances are not present. So, from the positive and negative history, we have basically tried to locate the lesion And also from the negative history, we are ruling out the other associated central nervous system anomalies that can be present. So to summarize, this is a 38-year-old female with signs and symptoms of transient loss of vision, on and off headaches, difficulty in walking, and frequent vomitings. The positive and negative history associated with this patient indicate towards the involvement of central nervous system and definitely presence of an increase in intracranial pressure. Now, coming to the anatomy of the brain. We have gone through the anatomy of the brain multiple times throughout our teaching and learning career. So to basically summarize, the cortex can be divided into the frontal lobe, the parietal lobe, the occipital lobe, the midbrain structures, and the contents of the posterior fossa, which is the midbrain medulla and the cerebellum. So the higher motor functions are associated with the cortical part of the brain. In this patient, we'll consider that these higher motor functions were normal. There are various tests to detect the higher motor functions. We shall not be going into the details of each of them right now. And one of the very important factors are the cranial nerves. These cranial nerves, as you can see, arise from the base of the brain, ranging from the first cranial nerve till the 12th cranial nerve. And they help in, and the symptoms associated with the affection of these particular nerves give us an indication of the actual localization or the exact point of the pathology. The 12 cranial nerves are associated with various functions, which we are very well versed with since our MBBS time. Now coming to the most important part of today's topic, which is the posterior fossa. The posterior fossa is the part of the brain which is the margins of which are formed by the clivus anteriorly and the foramen magnum. It contains the hypoglossal canal, the jugular foramen, the internal acoustic meters, the internal occipital crest, which you can see here. And the contents include the brainstem and cranial nerve, cerebellum, and blood vessels. So this is a better diagrammatic representation of the basic all components or anatomical components of the posterior cranial fossa. Now coming to individual parts, the foramen magnum is the largest foramen in the posterior cranial fossa. It is large and oval in nature, and through it passes the medulla oblongata, meninges, ascending spinal parts of accessory nerves, the vertebral arteries and plexus, anterior and posterior spinal arteries, and membrana tectoria and the alar ligaments. So any compression of these components may lead to clinical manifestations associated with compression of these components. Coming to the jugular foramen, which can be seen marked here, it is close to the inferior petrosal sinus. The meningeal branches of ascending pharyngeal artery pass through it, along with the 9th, 10th, and 11th cranial nerves. From here, it forms a sigmoid sinus, which ultimately becomes the internal jugular vein, and the meningeal branch of occipital artery also passes through it. The internal acoustic meters is also a component of the posterior fossa and houses the facial nerve and the vestibulocochlear nerves. So any vestibulocochlear nerve anomaly, usually acoustic schwannomas, are very common pathological features found in the posterior fossa tumors. It also houses the labyrinthine artery. Then coming to the brainstem, the posterior fossa also contains a part of the pons medulla oblongata and the midbrain. So these are structures. The importance of these structures is that it contains the nucleus of most of the cranial nerves and vital respiratory and other structures associated. So any anomaly can lead to compression of these structures, and that can be catastrophic. Now, the posterior fossa lesions, like all intracranial lesions, are broadly can be classified as vascular, infectious, traumatic, or neoplastic in origin. Another point of classification is whether they are intraaxial or extraaxial. That is, if they are within the pia mater or outside the pia mater. Now, 20% of all adult brain tumors are posterior fossa tumors, and posterior fossa tumors also are the commonest in children. Now, it also constitutes the cerebellopontine angle, and there are various cranial nerves arising in the posterior fossa, as we saw in the anatomy. So these also can be affected by any kind of tumors in this region. Now, the nervous system examination, as we are well versed with, includes the examination of higher motor function, the cranial nerves, and the motor and sensory examination
as well as of reflexes and cerebellum. So in this particular patient, we may consider that the power was good in all the limbs and everything else was within normal limits. Now, there is a differentiation between upper motor neuron lesions and lower motor neuron lesions. The important point here to note is that the main area of consideration is anterior horn cells. And for sensation, we can examine various components like touch, which can be crude touch, fine touch, pain, proprioception, and temperature. And usually these things are helpful in delineating the dermatological distribution and thus associating the level of pathology in case one of the components are affected. Cerebellum is a very big structure in the posterior fossa, and it is associated with very specific features which are specific for the cerebellum. It is associated mostly with the gait and balance, and so there can be disturbances of gait and balance if the cerebellum is affected. The patient might present with various features like nystagmus, and we can look for various signs also, like the finger nose test, fast pointing, intentional tremor, dysmetria, dysdiadochokinesia, rebound phenomena, gait, and Romberg test. Now, Romberg test is one important test used in posterior fossa tumors or in CNS examination per se, where the patient is asked to close the eyes with the heels together and stand first with open eyes and then with closed eyes. And if there is an affection of the posterior fossa components, then the patient may sway or fall when the eyes are closed for over a period of 30 seconds. Along with the CNS examination, we'll also go for the general examination and of other systems, as we do with all cases in the pre-anesthetic evaluation. So based on the clinical features and the tests that were done or examination, we come to the provisional diagnosis that it is an intracranial space-occupying lesion, probably in the posterior fossa with cerebellar invasion with features of raised intracranial pressure. Now, to establish the diagnosis, there are various modalities of investigation. One of the commonest and quickest to be done is the CT scan. The left image here shows the CT scan where you can see that there is a tumor, but usually it is not as good in delineating the soft tissue structures as is the case with MRI, which you can see on the right side. The upper one is the T1 weighted MRI and the lower one is a T2 weighted MRI. Now, one of the most common tumors in the posterior fossa is acoustic schwannoma arising from the 8th cranial nerve. And this is how it presents in MRI, where you can see that it is arising from the acoustic nerve and compressing the structures of the posterior fossa. And in the axial film, you can see that it is compressing on the midbrain structures as well. Then there can be meningiomas, which can arise from multiple sites, and they are delineated by the fact that they are good uniformly enhancing tumors on contrast MRIs. Medulloblastoma is a very common tumor presentation, especially in children. And as you can see, it is compressing the entire fourth ventricle and may lead to obstructive features very early before it presents with any neurological deficits. Then, as we saw, the pathway of CSF is there. Then it can choroid plexus papilloma can occur anywhere, including the posterior fossa, and cause compression of the pathway and lead to increased intracranial pressure. Along with the neurological evaluation and the investigations specific for the neurological case, there are other investigations that can be taken care of, like the routine investigations, which we do for all routine cases, which include the routine hematological examination, serum electrolytes, the renal function test, coagulogram, blood sugar, and ECG X-ray, depending upon the age and presentation of the cases. The common presentation of posterior cranial fossa, these patients usually present for the surgeries like tumor excision, which is the most common presentation, or they might have vascular lesions like aneurysm, AV malformation, and craniocervical anomalies like annual cherry malformations, for which they present for surgeries, or there might be cerebellar hematoma, evacuation, and decompression craniectomies to relieve brainstem compression in case there is a bleed or hemorrhage inside. So with this overview of the clinical manifestation and pathophysiology, now I will move on to the next speaker, which is Dr. Amlan.
It was excellent presentation, madam. and you so nicely explained about the anatomy, the contents in the posterior fossa, the cerebellum, pons, midbrain, what is exactly called as what is the function of medulla oblongata, and the most important thing is the cranial nerves nuclei, along with the afferent and efferent fibers. So this is very important to remember. The cranial nerve nucleus lies in the posterior fossa, and another thing is all three important sinuses, the transverse, the sigmoid, and occipital sinus, they also traverse the posterior fossa. So these are very important considerations as far as the anatomy of posterior fossa is concerned. This is because in the pre-operative examination, even we have to find out if there is any involvement of cranial nerves, and that you so nicely explained. And the most important thing as far as anesthesiologists are concerned are the lower cranial nerves. So the lower cranial nerves, the patient might get laryngeal dysfunction, patient might get hoarseness of voice, patient might get the cuff reflex might be poor, and these things are very important in the pre-operative period. This is because the post-operatively patient might need support of airway. We may not be able to extubate such kind of patients immediately after the surgery if the patient has lower cranial nerve involvement. So this is very important and very nice presentation, madam, regarding the history, the scan, the MRI findings. And now we are all eager to know about how you will manage these patients as far as the anesthesia management is concerned. So this with this basic knowledge of pathophysiology and anatomy of the posterior fossa, I invite Dr. Amlan sir to speak on posterior fossa tumor anesthetic management. Welcome, sir.
Good evening, ma'am. First of all, thanks a lot, Meenakshi sir, first for this platform to reach out to people to be able to teach and learn in the same go. Thank you, Manisha ma'am, for accepting to moderate this session. And without much ado, the first things first, we will get we have got a patient here with us who has now been diagnosed to have a posterior fossa tumor, and the onus lies on us to give an anesthetic management in which the patient will have the maximum benefit. So whenever we see any patient in the preoperative period, first of all, we go through the preoperative concerns, the intraoperative concerns, and the postoperative concerns. We try to address as much of it in the pre-op period. First of all, we make a problem list. These patients have a mass lesion. They may have or may not have a hydrocephalus. There are signs of increased ICP. Intracranial pressure has already been dealt very well by Dr. Murari. And there will be positioning issues, so we need to plan for that. Many a times, especially if the patient presents for some kind of emergency surgery because of impending herniation or other neurological emergencies, the full stomach might be an issue. Even in patients who are posted for elective surgery, because of ileus developing, there is a full stomach. We assume that these patients are full stomach. And also how we institute monitoring during the intraoperative period. So another concern, do we need to do further labs? Do we need to do further studies? Do we need to consult other specialty people? Because there is sometimes cardiac involvement, there are other comorbids. So we need to look at that. How much can we optimize this patient in the preoperative period as far as the comorbidities and the neurological injury is concerned, so that we get the best outcomes in the post-operative period. So the intraoperative and postoperative concerns would include pre-medication, monitoring issues, and how do we induce, maintain, what are the intraop complications we should look out for, and how then we go through emergence. Because some of it Manisha ma'am hinted on, and what are the postoperative concerns and complications. So this is the basic flow in which we will try to address these patients. Coming to the clinical presentation, as we have already discussed, these patients will present with features of increased intracranial pressure. There will be drowsiness, headache. These will be the presenting symptoms with which the patient will present, as also the fact that the patient will present with involvement of cerebellum and brainstem. Children, they will frequently present with hydrocephalus. So if the lesions are in the midline or in the fourth ventricle, truncal ataxia, gait disturbances, brainstem involvement will be common. And if this is a way to differentiate. If the lesion is in the cerebral hemispheres, then dysmetria, dysarthria, and late hydrocephalus will be common. And in the rarest but the most dangerous presentation, if there is herniation of the cerebellar tonsils, how will it present? How will these present in the ward? So any patient with a known posterior fossa tumor or signs of increased ICP, if the patient starts showing violent muscle spasms with meningismus, with nystagmus and typical posturing, then we should be suspecting herniation of the cerebellar tonsils. There will be occipital headache, and if this is not treated, this is one of the most dangerous things which can happen to patients with posterior fossa tumors, and there will be respiratory system involvement, the respiratory centers will be involved, and we might lose the patient. And in fact, there are paroxysms of coughing also, which happens when the herniation happens, and this causes further deterioration of the herniation symptoms. So what are our goals? Our goals are to facilitate the surgical access, because surgery in posterior fossa is a very, very challenging surgery. Any neurosurgical colleague, friend, senior you ask, they will say that this is one of the most difficult surgeries to perform. You want to do some form of neurological assessment along with the standard neuromuscular monitoring that you do for all patients these days. You want to minimize trauma to the intact brain. You want to maintain respiratory and cardiovascular stability, and you want to detect life-threatening complications, amongst which venous air embolism is, as we know, is the most important life-threatening complication that can happen intra-op, and we should be on the lookout for it. So what are the specific challenges? As I said, there are vital structures in a confined space. There is a complicated surgical access. The position is problematic. These surgeries are extremely, what could I say, difficult surgeries, hence take a longer duration, and there is a potential of hydrocephalus. So when we do a preoperative evaluation and preparation, what do? We evaluate the neurological condition. An extensive list of how to do that we saw in our previous slides. We look for cerebellar and cranial nerve dysfunction, because that will tell us if there is a loss of gag reflex, if the patient will require post-op ventilation and tracheostomy in the post-operative period. We see for the signs of elevated ICP. We also need to decide if we need a preoperative drainage procedure. We also look for signs of dehydration, electrolyte anomalies because of poor GCS, because of vomiting episodes, because of the patient being on diuretics. We have a look at the airway. We also try to manage the comorbidities the best we can. So the lower cranial nerves, as ma'am has already said, the 9th, 10th, 11th, and 12th. Some people say from the 5th to 12th, these are the cranial nerves which are compressed in posterior fossa, and their functions we should know, and we should understand that their functions are going to be deranged in these patients. If the patient is obese, you will have a difficulty. If the patient is planned for prone surgery, we have to plan for post-operative ventilation and tracheostomy. See if the patient has a patent foramen ovale, because that precludes use of the sitting position. And we will look at positioning in further detail. So how do we go about the pre-medication? For all comorbidities, whatever comorbidities are there, all those medications have to be continued. The basic important thing is that we have to be very careful while giving sedatives like narcotics and benzodiazepines. And we should be using prokinetics to help us in allaying the paralytic ileus that the patient already has. So these are the monitoring issues. So we will do the standard ASA monitoring, and there are certain specific monitoring that we need to do for these patients, which I will look into now. Some special monitors like the facial nerve function, when the neurosurgeon directly stimulates facial nerve, this is for vestibular schwannomas, and the facial movement is observed. And the anesthetic implication is that the neuromuscular blockade should be switched off when this thing is done. And the reduction in the size of the CMAPs of the facial nerve, this has been proposed by the National Institute of Health, that it is a prognostic marker for long-term outcome. Coming to the more important thing, the intraoperative neuro monitoring, which is coming up in a big way, especially in posterior fossa surgeries. It is very important. Brainstem auditory evoked potentials and SACPs, these are monitored. And the important thing that we need to know as anesthesiologists is to, first of all, maintain consistent and modest levels of inhalational. And the trend these days is to go towards IV anesthetic agents, avoid neuromuscular blocking agents. And the idea that we are going more and more towards closed loop and total intravenous anesthesia systems, so that we give a better patient outcome as far as monitoring is concerned.
So the auditory brainstem evoked response is important. And the most common changes seen here are the increase in latency of wave 5 and increase in latency of 1 through 5. So people who are doing it on a regular basis, and centers and as we speak, these number of centers are increasing in our country also. So this is something which is going to come up in a big way for tumor surgery, especially for tumors of posterior surgery, posterior fossa. So if you can look at this figure, see how the brainstem auditory response changes from baseline when the dura is opened, when the retractor is placed, adjusted, when the sponge is placed, when the retractor is out. So this gives a very good idea of how we are affecting or not affecting, the surgeon is affecting or not affecting the intact brain. And this is very, very important in preserving neural function. Auditory evoked response, the important thing to know, it is the most resistant to anesthesia drugs. Coming to the important patient positions that we might encounter in posterior fossa surgery. So first thing which I want to say is, depending on the surgeon, the location of the tumor, and the expertise with which the surgeon is comfortable with a particular approach, any of these positions might be required. So we'll just go through all of them. So like a supine position is like how it is shown here. We use a bolster, and brachial plexus injury and macroglossia are things which can happen because of this positioning. The important thing to note is that we have to keep an adequate distance between the chin and clavicle so that the airway is taken care of and the ventilation is maintained. Coming to the lateral position, this is for better surgical access. And here, the good thing is the venous air embolism incidence is very low and the hemodynamic stability is good. The demerits, the peripheral nerve injury and a ventilation perfusion mismatch because of the lateral position. Park bench position is one of now the newer crop of surgeons. They will mostly ask you for a park bench position because this gives the very good access to the midline structures. And these are the pressure points which we need to be taken care of. This is how we should ideally be looking for a park bench position. Not always possible in real life, but this is what we should be looking, or we should be trying to get in the operating room. And this is again a modified park bench position. And one of the most commonly used positions is the prone position, where there is access to the posterior fossa, craniocervical junction, and upper spinal cord. There is restricted airway access. There is risk of dislodging the airway over and above the normal cons of a prone positioning. All of these things also get added up in neurosurgery in prone positioning. There are horseshoe frames which can put a pressure on the face and orbit. All of these things need to be looked in detail. Coming to the most, the most interesting position. It was very widely used in the till the end of the last century, if I might say so. In the last 1 or 2 decades, there has been a quantum shift in people moving out from sitting position to these other positions that I have enunciated before. However, sitting positions still required by many surgeons. They will ask you for this, especially for surgical access, because it improves surgical orientation and access to midline structures like crazy, and it decreases surgical retraction. So it is a very, very interesting position. Here in this photograph, you will see two ways in which we can achieve the sitting position, and one of the ways is not very right, because in the case of a cardiac arrest situation or an impending cardiac arrest situation, that position will not be we will not be able to resuscitate these patients very hastily. So I leave it to the crowd, just a small sort of a quiz. Which one is something that we should not be practicing, A or B? So these are the complications. We have just put it in a table, all the positions. What are the complications? And the complications can start from cerebral ischemia to palsies to airway edema to pulmonary problems to cardiovascular perturbations to miscellaneous like eye compression, compartment syndrome, and venous air embolism. We will deal with venous air embolism in some detail in some minutes from now. So coming to induction, we should be avoiding anticholinergics, long-acting beta blockers. We should be using compression stockings, especially when we are planning for something like a sitting or a semi-sitting position. CVP institution and monitoring is the standard of care these days. We should be using IV opioids, any opioid, short-acting to long-acting opioids, depending on what postoperative course we are expecting. Propofol, thiopentone, or etomidate, depending upon the comorbidities, the propensity for hemodynamic perturbations. If you are planning a sitting position, all of this, etomidate in most comorbids does a fine job. And vecuronium is a muscle relaxant of choice because of its cardiac stability. And as all with all cases, you confirm correct ET tube positioning after final positioning. Many times there has been the endotracheal tubes sort of gets dislodged after the final positioning, and it is a nightmare in when we especially put the patient prone, or when the patient is made sitting, or the patient is in a lateral position. It's a nightmare. So be very careful about endotracheal tube placement in these cases. So how do we maintain anesthesia? We use controlled positive pressure ventilation. Earlier, there was a trend of keeping patients in the spontaneous respiration, especially in the time of ether. But now we paralyze all our patients, because then there is less of bleeding, the ICP is lower, there is less of patient movement, there is less of cardiovascular depression. So all this is an advantage of controlled respiration. Coming to something which is now an established, it was a burning topic when we were doing our post graduations and DMs. And it is still an ongoing topic, I might say, TIVA versus international. And so basically, with better and better technology coming in, target control infusions are something which are preferred. And because you get better analgesia, you prevent the stress response. And especially when you are fixing the head, when there is skin periosteum and dura mater incision, or when you're suturing the dura mater and scalp, that is when the pain and the stress response is the highest. And the biggest problem with inhaled anesthesia is brain relaxation. That is what has been touted. As I said, balanced anesthesia, total intravenous anesthesia versus inhalational anesthesia. So this is a study which was done in PGI and AIMS. And what they found that both propofol and desflurane were comparable. And so as of now, even though there is still a very big debate going on, and there are some people who will swear by total intravenous anesthesia, and there are some people who will say that inhalational still works. The debate, as I say, is still going on, but it's a personalized thing, and people can and are doing a lot of work with their own protocols. This is a summary of the effects of the intravenous and inhalational agents on the cerebral physiology. And these are the, as I said, these are the painful events which we should be looking out for. I've already discussed this: laryngoscopy, fixing the head in the headrest. And this is also, again, what is the advantage of a paralyzed patient vis-a-vis a spontaneous patient. For spontaneous patient, we have some examiners, they have the tendency to ask that we can do it in spontaneous ventilation. What is the problem? So fluid management, achieve near euvolemia, and especially when you are looking for a sitting position or a semi-sitting position, and there are some indicators of hypovolemia which you should be looking for. Systolic blood pressure fluctuations. We should have a CVP intact. We should be giving CVP glided fluids, and we should not be aiming for too high of a negative fluid balance. That was the earlier teaching, that in neurosurgery we should be having for a negative fluid balance for a less edematous brain and all. But now the consensus is that we should not be doing too high of a negative fluid balance. And foremost, we should be eternally vigilant. We should be eternally vigilant for hemodynamic perturbations. We should be vigilant for tight brain, arrhythmias, blood loss, and last but not the least, venous air embolism, where air enters into the circulation and causes all kinds of havoc when it enters through pin sides, burr hole, and open sinuses. So we'll discuss venous air embolism in some detail. It's a very interesting and a very big topic. And in addition to those operative sites, it can, as I said, it can happen through non-operative sites also. It can happen through loose connections on venous lines also. It can occur any time the vein is open and a gradient of about 5 centimeters of water exists between that open wound and the heart. And children, unfortunately, when it happens, they have a worse morbidity and mortality. And hypovolemia, because of a low CVP, increases the gradient. So it is directly, the morbidity and mortality is related to the volume of entrant, rate of accumulation. Adult lethal volume is around 200 to 300 ml or around 3 to 5 ml per kg. And closer the vein of entrainment is to the right heart, the smaller the lethal volume is required. That makes sense. Because the lethal volume is when it goes and clogs the right heart outflow tract, that is where it starts causes the pathophysiological problem. So it can happen in two ways. In the upper diagram, it is a slow, continuous air into the venous system, and sometimes it can be a large and rapid inspiration into the venous system. And it will have various major systemic manifestations. The cardiovascular manifestations will be anything from a decreased venous return to myocardial ischemia and cardiac arrest. A pulmonary manifestation will basically finally present as hypoxia and hypercapnia, and CNS hypoperfusion can cause delayed onset strokes and delaying poor GCS to cerebral ischemia. So this is the clinical spectrum, the presentation of the clinical spectrum when the air entrainment happens in patients undergoing posterior fossa surgery. And if you can see, if it is a small amount, there will be only changes on the monitor and desaturation. And if the volume is large, there is chest pain and right heart failure and cardiovascular collapse. So all of this can happen. And in between, as I said, myocardial ischemia, mental status alteration, hypoxia, all of that is happening. So patent foramen ovale causes this paradoxical air embolism, and hypovolemia predisposes to this. How do we detect it? Transesophageal echo, highest sensitivity, and in the invasive is the highest sensitivity. And precordial Doppler has also got a high sensitivity. It is the most sensitive non-invasive test. And other things that we can use is the PA catheter, end-tidal nitrogen, end-tidal carbon dioxide, and saturation. Saturation is a very low indicator. So if you are picking up venous air embolism in a surgery, when the saturation is going low, a lot of the damage has already happened. So this is a table where we have sort of summarized the advantages and disadvantages. For the Doppler, as I said, is a sensitive non-invasive test. And however, it is difficult in obese people, deformed chest, in prone positioning, lateral positioning. There is interference with electrocautery, and IV mannitol will mimic venous air embolism with Doppler. Similarly, for a PA catheter, it can detect RA pressures, and because of the small lumen, it is not always possible to aspirate through the PA catheter. And again, end-tidal carbon dioxide is non-invasive, highly sensitive. End-tidal nitrogen is more specific for air, but it may not detect subclinical air. And as I said, the most sensitive can detect left heart air. Aortic air also is transesophageal echo. But the disadvantages, it is invasive, cumbersome, experience, requires a learning curve. And so these are the things which will, but as we speak, more and more centers are having a transesophageal echo, especially where they are doing posterior fossa surgeries routinely. And this is something that is very much required, at least in the centers who do high volumes of these surgeries. Though the severity of venous air embolism, as I said, grade 1 is only microbubbles, and grade 3 will be with microbubbles with a sudden decrease of end-tidal carbon dioxide and a decrease of mean arterial pressure by at least 20 millimeters of mercury. So central venous cannulation is important both for monitoring as well as for aspirating. And in this case, the multi-orifice catheters are better. And the tip, you should see, it should be 2 centimeters below the SA node. And even though it is from there, you can remove a lot of air, you may not be able to remove all air. So the vigilance of the anesthetist is very important, as I've already said. Some late signs could be there. There is a decrease in oxygenation on ABP, and there will be Millville murmur and a cardiovascular collapse in the late stages. How to prevent? You avoid high-risk positions, talk with the surgeon, and have a detailed discussion, especially in terms of comorbids. If the hemodynamic status is in the pre-op condition is very poor, tell them that there is a very high chance of venous air embolism. Try to explain the risk versus the benefits of certain positions. control ventilation, using of PEEP, will come to that. Maintain an adequate volume status, sacrosanct. Careful dissection and liberal use of bone wax, avoid nitrous oxide, and try to keep the venous capacitance in the normal range. And when it happens, what do? You inform the surgeon, you tell them to flood the field with saline so that further entrainment is decreased. You do a jugular venous compression, stop nitrous, increase FiO2. Where in centers where they have medical air, these surgeries are done with medical air and total intravenous anesthesia. You aspirate via the RA catheter. You give cardiovascular support, you initiate it, and as required, you can continue into the post-operative period. And of course, you change the patient's position. Durance position is something which is very famously described in books and should be remembered. PEEP is controversial because it can increase CVP and it can therefore decrease venous air embolism. But however, it has a concomitant effect of decreasing the cardiac output. So it can increase chances of the paradoxical air embolism. So this is something which we should know when we consider PEEP, especially when we are trying to treat, either we are trying to give it equivocally for neurosurgery, mostly we try to avoid it. And when we are trying to treat VAE in a ongoing posterior fossa surgery, these things should be remembered. So postoperatively, anything from supplemental oxygen to hyperbaric oxygen therapy, everything is used, and they have shown if the level of VAE insult is less, supplemental oxygen will work. But in severe cases, hyperbaric oxygen therapy is also required and is found to be helpful. And what are the other things other than VAE which can happen? As I said, the tight brain can happen. That is where the class by Dr.Murari comes in handy. So this is how we go through a tight brain checklist. We first look at positioning, we look at airway ventilation, then we look at the anesthetic and metabolic causes, and then we look for surgical causes. So this is the basic flow chart in which we should be looking at a tight brain in whatever scenario that we are getting neurosurgeries done. There could be sudden cardiovascular changes like hypertension, there could be arrhythmias, there could be bradycardia, and there could be a lot of intraoperative bleeding. There could be ventilation problems because, as I said, because of if the tracheal tube especially is not properly fixed, and there could be premature ventricular contractions because of potential causes which we have mentioned here. Emergence of anesthesia, there are important things. We should be preventing an abrupt rise in blood pressure. We should be ensuring a rapid awakening. We should be planning awakening from the pre-op phase and looking at the intra-op phase. Then only we should be planning awakening. We should be minimizing coughing and straining on the endotracheal tube. And we should have a secured airway till the patient is awake, following commands, and there is return of protective airway reflexes. This is very, very important when we look at emergence from anesthesia for patients with posterior fossa. And there are some caveats of early versus delayed awakening. So what are the factors? The early awakening will be associated obviously with lower cardiovascular and catecholamine changes. It will be associated with immediate post-operative neurological assessment, gives a very good idea of how the surgery went. It will be, then you can avoid all those post-operative intensive care and ventilatory problems that happen, starting from infection to many other things. But sometimes, especially in patients with poor cognition and poor pre-op status, the delayed awakening allows better control of oxygenation but it is associated with a delayed neurological examination. So what are factors which will affect if you extubate the patient or not? As I said, preoperative neurological status, the intraoperative course, and the airway reflexes at the end of surgery. Because please remember, they are doing surgery in a place from where the airway reflexes centers are there. So during the surgery only, the airway reflexes can be hampered. And we need to have a detailed talk both with the patient's relatives as well as the surgeon regarding this in the preoperative phase, explain it to the relatives that this can happen, and so that everybody on the team is on the same page regarding this. So what are the other post-op considerations? Hypertension is common, that can lead to edema and ICH. So in the post-operative phase, we should be treating the common causes of hypertension. There could be neurological complications like altered sensorium paresis, including facial nerve palsy, cranial nerve deficits, visual defects. Cerebral embolism, as I've already said, might require hyperbaric oxygen therapy. And we will look at 3 or 4 important post-op considerations like pneumocephalus. And what is pneumocephalus? Pneumocephalus happens because of these things. Because when there is shrinkage of the brain because of mannitol, hyperventilation, or SOL removal, because of that, this pneumocephalus happens. And how does it present? especially if you are extubated, this patient will have a delayed recovery or a neurological deficit, or there will be convulsion. And when you do a scan, you find a tension pneumocephalus or a pneumocephalus. And what is the treatment? Oxygen. And in severe cases, you do a twist hole, twist drill burr hole. Like I was saying, this is that inverted pop bottle analogy. So as the CSA pours out, the air bubbles go to the top of the container. Hence, especially in the sitting position, this happens a lot. So be very careful, especially in sitting or semi-sitting position. It happens in other positions also, but more commonly in this position. And there is a role of nitrous oxide in pneumocephalus. So please try to avoid it. If there is medical air, as I have already said, it is a very good thing to use. And twist drill aspiration of the air through burr hole on either side of the vertex can be life-saving. Something which is especially in patients with children with medulloblastoma, lack of speech, which is not associated by or not explained after surgery by other. You have to rule out these things: long tract signs, cranial palsies, poor consciousness, and then this is known as cerebral mutism syndrome, or also known as the posterior fossa, part of the posterior fossa syndrome, especially found in children with medulloblastomas. Macroglycia can happen, especially in because of flexed neck, lateral positioning, and long surgery, and it can cause postoperative respiratory obstruction. This itself can be a reason why we cannot extubate a patient in the immediate postoperative period. Quadriplegia can also happen, and the important thing to understand is you avoid significant and prolonged hypotension during surgery. And to conclude, posterior fossa surgery, definitely it's a challenging surgery, but it is very, very rewarding also. And a thorough pre-op evaluation, looking at the positioning, how do we choose our anesthetic agents, doing a deep dive into the monitoring world, especially with intraoperative neuro monitoring coming in a big way, and watching out for complications like VAE and looking out for tight brain and preserving neural function is a priority. If you can do that, we can really make a difference in these surgeries. Thank you for such a patient listening. I hope we just finished in time. It's a big topic, and thank you to my co-speakers also for doing a wonderful job with their parts. And over to you, ma'am and sir.
Excellent presentation, sir. Such a vast topic.
Yes,
So many things to be discussed. Venous air embolism, positioning during surgery, monitoring, the special neuromonitors that are used. So many things were there. The post-operative complications that are associated with posterior fossa surgeries. I think you covered everything in last 20 to 25 minutes. And I must say it is one of the excellent presentation for posterior fossa surgeries. And the most important thing that you stressed upon is what I liked was the eternal vigilance. The eternal vigilance by the anesthesiologist is very important in such kind of cases. The vigilance, in fact, it begins from the when we start seeing the patient, right? From pre-operative evaluation till the decision about emergence or decision about whether you want to have an early emergence or delayed emergence is really important. And this is like a book. A posterior fossa surgery, a book can be written only on such kind of surgeries. And as you said correctly, whenever you get a case of posterior fossa surgery, whatever the position the surgeon prefers, because usually we do not have any choice of telling surgeon that please do not operate this patient in this position, because it is usually surgeon's choice. But the way you explain the complications of each position, and also you explain that sometimes you have to say no for certain positions, like the sitting position. It cannot be given in a patient who has, suppose, a VA shunt, ventricular atrial, which is done very rarely now. But suppose a patient who has been done a VA shunt, yes, we do it routinely. We do not do it routinely, but sometimes if the VP shunt fails, then if there is no option left, and the patient frequently comes with obstructive hydrocephalus, then sometimes rarely VA shunt is performed. So in such kind of situations, it is absolute contraindication to give sitting position. Patent foramen ovale is also one of the relative contraindications. So you have to put your foot down whenever, or a patient of extremes of age with hemodynamic instability. You may feel that you nicely explained that if there is a rise in position, if you give sitting position and if there is a rise in position above the heart level by 1 centimeter, the BP falls by around 0.75 millimeters of mercury. So such kind of relationship is important, and there you have to, if there is a extremes of age or if a diabetic patient with autonomic neuropathy, then such kind of patients, hypotension may occur, hemodynamic instability may occur. And you so nicely explained about all these positions, different positions, their advantages, their disadvantages, and which position to be like you have to request sometimes, you have to put your foot down there. Sitting position is not possible for this patient. So I must say it is one of the excellent presentation, and to cover up such a vast topic in 20-25 minutes would have been really impossible. Thank you so much, sir. Thank you.
Actually, can I tell something, sir?
Sure, sir.
Yeah. I think that even the discussion with the relatives about how the course can happen that is something, especially in these cases, we should be looking at. We are talking with the surgeon and all. Sometimes in all of this, I think the primary caregivers, the people who will give care, who are in a state of anxiety and who will be giving care after surgery. I could not make a slide about it. I just alluded to it in a certain way, but I must say that it is very important that we discuss the post-operative course, the probable post-operative course with the relatives. And as far as positioning goes, ma'am, we can only talk with the surgeons, but we have to be mentally prepared, knowing that all this can happen, that if the surgeon requires a position we have to give, at least we should know the theory and the practical aspects, so that whatever position comes, we can manage the best.
Yeah, that's what I said.
Yeah.
We don't have any much to say
Right.
when the positioning is. So you perfectly said that the informed consent, you have to talk to the patient's relative. You have to do a thorough counseling. You may not get a chance. Suppose something goes on intraoperatively. Suppose there is some hemodynamic instability, extensive excision of tumor, massive blood loss, then you may electively ventilate such kind of patients. So even if the neurological status might have been, the GCS might have been 15 by 15 preoperatively, but then because of some surgical complications, some intra complications, you might have need to ventilate such patients post-operatively. So in such cases, in every case of, in fact, neurosurgery, and more importantly in posterior fossa surgery, which is always important to explain the patient all possible complications, and also tell them that this patient might need post-operative ventilation, and everything depends upon the intraoperative course. So you correctly said, sir, that discussion with the patient's relative is very vital. Neurosurgeons, yeah, we do talk, we do discuss with him regarding the position, the course of surgery, but discussion with the relatives is also very important.
Yes, it's a team effort.
Yes.
Dr. Amlan Swain, can you please stop sharing your slide?
Yes.
Stop sharing so that screen will be seen. That's nice. So now, see, it is an excellent lecture. See, I am happy. This posterior fossa surgery is a essay question for postgraduates. And venous air embolism, somatosensory evoked potential, brainstem auditory evoked potential, these are all short notes. And see, this man, Dr. Amlan Swain, covered the essay question also. Same way, every short notes also. Positioning also short notes for them. So everything he has covered. So I think even people who are not listened it live, we will give a YouTube link. So I think it will be most sought after one. And I am happy to see he has put 3 question marks regarding PaCO2 kept between 25 to 30, 3 question marks, because nowadays actually it is not practiced. When I was a postgraduate, they asked me to ventilate 60 times per minute so that hypocarbia will be there. So
sir, actually, I have a tendency to ask a lot of questions. Somehow, when I make presentations, I tend to.
Yes. That shows your experience. We are very happy, and madam, we are seeing some 2 comments actually.
Yes.
One is the excellent crisp presentation, easy to understand. Well done, Dr.Seelora, Dr. Sashikant. Another one, what is the significance of history of patient unable to comb? Dr. Manisha Sahariyar has asked that question. Comb. Is there any significance in that?
There was a point where the patient is unable to comb and unable to wear slippers. That is fine motor functions of the nerves. So if the nerves are involved, that is there. The one of the first earliest signs of neuropathy is that the slipper slips away from the foot. That is because the tone and muscle power is lost in the toes first before it progresses to other parts of the body. So if there is spinal cord compression, which is leading to, or there is nerve compression of the nerves arising from the vertebral column, so there it can be a problem to do minor and fine motor functions like combing your hair, raising your hand above the head, or having the slippers. So basically, it was part of the negative history to rule out other associated neurological um, uh, involvement.
To basically pinpoint the lesion. So,
as much as the positive history is important, equally important is the negative history, so that we rule out.
So the idea was that when we are taking a history, just on the basis of the history, if you can pinpoint the site of the lesion, and then of course we go on to do an examination, and after that
investigation.
After that again we try to put up a provisional diagnosis, because that is how you are expected to present in a long case also. So that is why that was there.
Just to add to what Madam has said and Madam and Sir has said, see, the posterior fossa is not always tumor.
Yes.
It can be venous, it can be a vascular malformation, it can be a traumatic extradural hematoma, or it can be a cervical lower posterior fossa or a cervical lesion like atlanto-occipital orbital instability or Arnold-Chiari malformation. So such kind of lesions are, all these cases need posterior fossa decompression. So as Sir said correctly, the history will tell you exactly pinpointing where can be the lesion, whether it's a tumor, traumatic lesion, or whether it's an infarct, whether it's a vascular malformation, or whether it is related to cervical, the occipital, atlanto-occipital instability, or maybe an Arnold-Chiari. So such kind of history is very important as far as knowing about or pointing towards the possibility of lesion. So that's why this question was put by Madam.
Great, madam. That shows your experience. Dr. Amlan Swain, I have a question for you. You said explaining the risks to the patient's attender is a must. Actually, that is a soft skills for anesthesiologist. We have to do that. But I want to know, in your setup, probably it is a corporate unit. So whether you think if you explain that this can happen, that can happen, that can happen, whether your surgeon allows that to be deliberately informed to them, because our private practice, the surgeon will say, sir, you said that there may be a death in the perioperative period, so the patient is reluctant to accept surgery. So how do you face it?
Sir, yeah, so it's a very pertinent question and something which is very close to my heart. First of all, I must say that where we work, it is not really it's not really a corporate setup, sir. We have the full independence in talking to the patients, and we have got 4 neurosurgeons, sir, and all of them are fantastic human beings. Surgeons, they are very good, but the first thing is that all 4 of them are fantastic human beings. And both when we are prognosticating, many a times both the neurosurgeon and us, we prognosticate together. We explain to them, and with the idea, again, our organization takes care that they teach us a lot of soft skills. And what we have learned is we tell them the risks, but the onus is on us to not frighten them. So the onus is on us to reassure them that, see, these are the risks. We have got very good modalities now, starting from operative microscopes to very good anesthesia drugs, but still things can go wrong. Rest assured, if anything goes wrong, we are prepared for things going wrong, and the organization and the institution will take care of it. But that is not to say that there are many non-employee patients also, sir, patients who pay. So we also take we do an extended session, and we actually explain the what should I say, the probable financial financial implications there also. And we explain to them that we will be taking in writing, and this is all so that all of us are on the same page, all of us are a team. I to sir start with one thing. We cannot do, I tell it in Hindi because Hindi is the predominant language here. I tell them that this surgery cannot be done without all of us being on the same team. It takes some time, sir, but believe me, it is a beautiful experience. And even we have lost patients after, sometimes it happens, but the relatives have never gone with a complaint in their heart. And
Madam, you are purely a private setup. In your Balwant Institute of Neurosurgery, how will you manage this soft skill, madam?
Yeah, sir. Ours is a tertiary care center, so the patient is usually referred to us. The diagnosis is done at somewhere outside. The patient has been shown to some neurosurgeons, and they have done the job of frightening to the patient. What the patient is already frightened outside, and they must have inquired 10 times to many people where to go. This is such a big tumor, so the patient will be referred to us. So that frightening part is usually over, and when they come to us, the counseling part usually starts. We need to counseling them. So what sir Dr. Swain said, usually we do counseling differently too, not together, because the times do not match. So maybe the surgeon has already done a counseling in his OPD, has explained everything, and when the patient goes home and then come back with the preparations for surgery. So when I see the patient, the neurological complications has been already explained to the patient by the surgeon. So I usually discuss that. Are you aware about the surgical complications? Do you know? Have sir explained to you everything? So they say yes most of the time, because the extensive counseling has been already done by the surgeon. So for me, the job becomes little easy. I explain them all the anesthesia complications, right from delayed awakening, whether it may be anesthetic reason or a neurosurgical reason, but then right from delayed awakening to the possibility of air embolism and the risk to the life, and everything I explained. And to my experience, none of the patient has gone home feeling that surgery may create problems to his life. So whenever, but that such kind of, because communication skill is one of the important non-technical skills, and it is the way how you talk to the patient. You have to explain everything, all the risks that are associated with the surgical and anesthetic interventions. But at the same time, you have to convince in such a way that the surgery has to be done. And this is a tact that we have to learn slowly, and the PG students must get aware with this, because in our day-to-day PG teaching, communication skills are not taught routinely, but then we have also learned it away when we did post-graduation. Definitely it was not taught. Now at least it is included in the curriculum of the PG students. So communication skills have to be learned by looking at the way your teachers speak to the patient, with your seniors speak to the patient. So I'm sure that if you convince the patient in a proper language, in their own native language, what sir said, he speaks in Hindi, I speak in Marathi, or maybe sometimes Kannada, taking help of a person who speaks good Kannada. So such kind of thing is required, and the counseling has to be done basically with patients' close relatives. You should not scare the patient. You should tell silent points to the patient. Like I usually tell the patient that tomorrow, the female patients are usually reluctant for shaving of head. And we have so many patients who come from Karnataka and they're fond of going to Tirupati Balaji where they donate their hair. So I usually tell them that tomorrow we have to go to Tirupati Balaji, and we will be, so they really accept it, and you start worshipping Tirupati Balaji, and the surgery will be successful. So many times the relatives even tell us that you don't tell the patient that it is an extensive surgery because he will get frightened. So that also you have to tell in a very sweet way to the patient that will just take you to the OT, and we have to do a CT scan, and that CT scan will will not be done in a proper way if there is hair on your head. So such kind of things we have to talk to the patient relatives, also convince the patient in such a way that he is not scared for the surgery, and tell extensively in detail about all the complications to the patient's relatives, so that they will also be ready for the surgical intervention. If it is an emergency situation, like suppose extradural hematoma in the posterior fossa, usually they expect all the complications. But if a patient comes walking to your OPD for the surgical intervention and suppose he develop complications, then the counseling is the most important part that will save you from anything, from any adverse effects as far as the reactions of the relatives are concerned.
Thank you, madam. Yes.
Actually, in this age when everybody is so well informed about everything, when they hear all that from us, it develops confidence in them regarding our management of the patient also. And that is how they sort of also analyze and gauge that, okay, these people are experienced, they know, they have dealt with such kind of cases, and they feel a bit reassured regarding the management that the patient is in safe hands. Because obviously an informed and learned relative, the compliance and the dealing with them is much better as compared to somebody who has not been informed about the complications, and later when the patient lands up in a complication, then they go ballistic, and then it will be a catastrophe.
Madam, there are no questions. You, madam, if you give your concluding remarks, we can hand over the section to vote of thanks.
Yeah. So what I can say, it was an excellent presentation by all three speakers. Dr. Bharadwaj was sitting behind sir and madam, but yours was an excellent presentation at the postgraduate level, I must say, because you just, yes, I know that you have been supervised by your teachers, but then whatever
No,
goals,
I must tell, we did not supervise anything.
yeah, then it is really excellent.
That's the reason
I'll tell you.
probably,
He
madam,
was
probably he wants to say just because they have not supervised, he has become intelligent.
Yes, exactly. He's so good. He's so good. I must tell, he's so good that he was actually after me, sir. Did you look at the presentation? Yeah, I am not.
He is your backbone. He is your backbone.
I just told that you will do fantastic job. Let me concentrate on what I have to do, because I have a lot of doubt on myself. So don't worry about you. I am 200% sure that you will do a good job. So don't worry about that. So he's very good, and he's going to give his exams now. And he's actually made the presentation, and
All by himself, we didn't do it.
we didn't do anything. And he's that good in our forums also. That is why, because we were given an opportunity on the national forum, I said ki we should come out with our best people.
Yeah, he must come to the PGCon or the Yuva ISACons, which are happening now at the national level. Recently, it's happening at Hyderabad also in next maybe after 10 days. So
Yeah.
I should see Dr. Bharadwaj personally there presenting some interesting paper. Still the abstract, the lines are still open. So I must say, Dr. Murali, please check the website and do come. And if the lines are closed, just let me know. I will and present an interesting case or maybe something you are studying. And such kind of people or such kind of UA Asians are definitely required. They are the future of ISA. Those who are interested in academics as well as in knowing in our presentations, so they are required. So thank you very much, Dr. Murali and Dr. Bharadwaj. And yes, both of you, that couple, Dr. Swain and Madam, you did a wonderful job to the topic that has been allotted to you. In fact, I was worried. What I will say, these two people I have learned by experience. I'm not the Neuro Anaesthesia. When I completed my MD Anesthesia, that time DM was available only at, not DM, it was a fellowship at Sri Chitra with the cardiac and the neuro fellowship 6 months. No DM course was available. I appeared for that exam. I was studying in Tata Memorial Hospital, Mumbai for my MD. I appeared for that exam. I passed with flying colors. So I was supposed to go to Sri Chitra, but then there were some family commitments as I was completing my post-graduation, and as I was already away from my family, my husband, for almost 2.5 years of my MD post-graduation. So some family commitments, and so I had to go back to Solapur. I still miss that I have not, and I still feel that, in fact, I was worried these 2 DM people will be there, what I am going to speak. And because they have spent 3 years in learning neuro anesthesia, which I have learned in a hard way by experience and by reading. But then you did a wonderful job.
Even we learned it the hard way, and believe me, you are very senior. My father is also an anesthesiologist. He tells, if you learn things the hard way, they stick with you for life, and they always, it is something else. So I believe, and you have learned. We always have seen you in neuro conferences and neurocritical care society. So yes, ma'am. So thank you for this.
Madam, I request to ask you two personal questions, madam.
Yes,
One, how do, in your opinion, in life, which is better, to neuro anesthetists as life partner or neuro anesthetists with a neurosurgeon as a life partner? That is one question, madam. Number 2, how do you like the neurosurgeon is operating and her spouse is anesthetizing, how the surgeon accepts it or how the spouse accepts it?
So answer to my question, if you're a surgeon, see, you forget when you are operating together, whether your husband is a surgeon or your wife is an anesthetic. So it's a team again, the surgeon and the anesthesiologist. So whenever, it is very difficult to say whether two anesthetists, but if they are in private setup, definitely they will mutually help each other. And for as far as the surgeon being anesthetist and wife anesthesiologist in a private setup, definitely it is an extensive, or definitely I can say it is a very good teamwork, because the surgeon can concentrate on OPD, the anesthesiologist can manage the perioperative part, can look after the ICU, and can manage everything, including the patient's counseling. So the neurosurgeons, it's very hectic and tedious for them to operate every day and then concentrate on the post-op course also. So if the companion or the wife is an anesthesiologist, they feel relaxed because they need to have someone who is dedicatedly working for them. If I'm not there and suppose the anesthesiologist is called from outside in my absentee, then the anesthesiologist is always in a hurry to go for the next case, and he will hurriedly extubate the patient. The patient is still drowsy, and then my surgeon definitely misses my expertise in such kind of situations. So this is very important. A team is required for neurosurgery or a neurointensive care. And the most important thing I'll say, whenever my husband calls me madam in the operation theater, I have to realize that something is going wrong. Something is going wrong, because he usually doesn't talk to me also in the operation theater. But when he'll say madam, something if he says with the madam, otherwise he will not take even my name also. Whatever I have to ask, he'll just ask like that. But when he says madam, then I have to understand that something, I have to check the blood pressure, I have to see something. So that kind of mutual respect for each other and mutual understanding is very well there when your companion, your husband, your spouse is the neurosurgeon and you are the anesthesiologist, or maybe vice versa, because I've seen a vice versa, the other situation also, the wife neurosurgeon and the husband anesthesiologist. So I have seen one couple like that also. So that mutual respect and the teamwork that can be built over years when you practice neuroanesthesia and neurocritical care.
Thank you, madam. Now I request Dr. Kayama, our treasurer, to propose vote of thanks.
Good evening, everyone. I thank you all for your participation in the 13th episode on Puthukkottai Bhudhan webinar series, second edition. Our sincere gratitude to our academic chairman, Dr. A.L.M. sir, who is a pillar of strength in the Puthukkottai Bhudhan. I thank Department of Neuro Anesthesiology, Tata Main Hospital, Jamshedpur, Jharkhand on this topic on anesthesia for posterior fossa tumors. I thank you, Dr. Murari Bharadwaj, Dependent Resident, Tata Main Hospital, Jamshedpur, Jharkhand. So it was a clean presentation on ICP waveform components and monitoring techniques. Thank you, Dr. Murari. I thank Dr. Seelora Sahu, Senior Consultant, Tata Main Hospital, Jamshedpur, Jharkhand. Madam, you have given a detailed presentation on anatomy, investigation, and in the clinical manifestation in the presentation of posterior fossa tumors. Thank you, ma'am. I thank Dr.Amlan Swain, Senior Consultant, Tata Main Hospital, Jamshedpur. Sir, you have stressed the importance on preoperative concerns, both for elective and emergency surgeries, the challenges, intraoperative monitoring systems, patient positioning, post-operative complications, and the vigilance of anesthesia, and also the discussion with the relatives. Thank you, sir. I thank you, moderator, Dr. Manisha Katikar, consultant, Balwant Institute of Neurosurgery, Trauma Care at Solapur, Maharashtra, for guiding us in today's episode. Thank you, ma'am, for your continuous support on Puthukkottai Bhudhan webinar series. I thank Clarinet for your continuous support. I thank all the participants, consultants, postgraduates, faculty,